Hello, everyone. Today we are talking about ventricular and non-pulsatile rhythms. So this is session 4 of the summer ECG series. Coming up next is going to be heart blocks. So as always, this was in collaboration with the Ottawa Hospital, Kingston Health Science Centre, and the University of Ottawa Heart Institute. And also, as usual, we have our disclaimer that we do our best to provide as up-to-date information as possible, but we're human and sometimes we make errors or we're not quite up to date. So if there is ever anything that doesn't make sense or is not how you know it to be, please let us know. We are always open to learning. ECG interpretation and treatments are complicated and things are always changing. So we are always open to feedback that maybe we're not as up to date as we thought we were. The other thing that I always like to mention is patients are complicated beings. We always have to take into consideration individual patient conditions, the clinical circumstances, and our institutional policies. Use this information to support your critical thinking, aid you in making informed decisions, but do not use it to replace clinical expertise, institutional protocols, physicians' orders, etc. We still always have to follow our organizational guidelines and our physicians' orders. Today, we're going to skip over the things that we've been covering at the beginning of every session. So our conduction system, our normal components of our ECG interpretation, and our steps or rhythm interpretation. Up to this point, we've covered it for every session. So I'm hoping you all have a good foundation in that. If not, you can always look at the slides or go back to the previous sessions for review on those. So today we're going to jump right ahead to our ventricular rhythms. So our ventricular rhythms, the thing about our ventricular rhythms is that they originate in the ventricles, which makes sense. They're coming from the ventricles of our heart or the bottom of our heart. Our ventricular rhythms or beats will not have a P wave. Okay, and if you think about it, this makes sense. So our sinoatrial node is up here. When we have beats that originate from our sinus node, it causes atrial depolarization. It gives us a P wave. When we have beats that occur from our AV junction, it gives us P waves, but they're upside down because the P wave is traveling backwards to the sinoatrial node, right? So when our beats are generated from our ventricles, our depolarization cannot travel backwards through the AV node. So it's going to be blocked at the AV node. So it's not going to go back. Therefore, these rhythms are not going to have a P wave. Additionally, because the rhythms themselves are not following our typical conduction system pathway, the complexes themselves are going to be wide. And this is because rather than following our beautiful conduction superhighway, the depolarization is going to actually transfer cell to cell, and it's going to take longer. So in our ventricular rhythms, there's going to be no P wave, and our QRS complex is going to be greater than 0.12 seconds, generally speaking. The first thing we're going to talk about is our premature ventricular contractions, or our PVCs. PVCs by themselves are not a rhythm, and they're going to be interpreted as a rhythm with PVCs, such as normal sinus rhythm with PVCs, atrial fibrillation with PVCs. By themselves, it means nothing. A patient having PVCs, we need to know what else is going on. PVCs are characteristically going to be wide and have a discordant T wave, which means the T wave is going to go in the opposite direction of our QRS complex. Okay, so you can see here the QRS complex is a downward deflection or a negative deflection, and the T wave is a positive deflection. So this means it's discordant, it goes in the opposite direction. This is characteristic of our ventricular rhythms. If you see our regular rhythms, the QRS complex goes up and a T wave goes up which is the opposite of our ventricular complex. Okay, so when we see a rhythm with PVCs in it, the rhythm itself overall is going to be irregular, but the underlying is usually regular. Again, the underlying is really dependent on what the underlying rhythm is. If it's atrial fibrillation, it's going to be irregular. If it's a sinus tachycardia, normal sinus rhythm, sinus brady, it's going to be an underlying regular rhythm. The rate, again, is going to be dependent on our underlying rhythm. However, because our PVCs, or premature ventricular contractions, do not have a P wave, your ventricular rate is technically going to be greater than your atrial rate. Our P wave, again, assess your P waves in your underlying complexes. The PVC will not have a P wave, and again, it's because it's originating in the ventricles. That depolarization cannot go up and back through the AV node. Our PR interval on our PVC, we cannot have a PR interval because there's no P wave. So again, you'd be assessing this on your underlying rhythm. The QRS, again, on the PVC is going to be wide and bizarre. It's going to be greater than 0.12 seconds. And the PVC configuration will differ from the underlying QRS configuration. So you can see that this looks way different from the other complexes that you're seeing. It's originating in a different spot. This one is originating in the ventricles. It's not following the conduction superhighway. It's transferring cell to cell. The other thing I like to mention when we're thinking about QRS complexes or with our PVCs, the number of morphologies that you can get is in the thousands. Literally depends exactly where they're coming from within the ventricle themselves to how they're going to look. So they can look so many different ways. The T waves, again, they're going to be discordant in the opposite direction in our PVC. The other T waves, again, dependent on our underlying rhythm. When we're measuring our QT interval, we're going to measure it on the underlying rhythm, not on the PVC. And under other components, the other thing that you'll generally see is a pause after the PVC while the kind of conduction highway resets and starts back into the normal sinus or the underlying rhythm. Okay, so when we're thinking about a PVC, it's a single ectopic impulse originating from somewhere in the ventricular myocardium. Okay. This is kind of to give you an idea of where our beats are coming from. So you can see in this rhythm, we have a underlying sinus rhythm, and then all of a sudden we have a PVC. So the blue here indicates these are coming from the ventricle, and we can see these have beautiful P waves, normal, narrow QRS complexes. Those are coming from our sinoatrial node. Okay, and you can see after both of these PVCs, there's a little pause before the regular underlying rhythm takes back over. When we start to get worried about PVCs is when there are a lot of them, when there is many in a row. So we'll get into it. So if we have two PVCs here, or if we have two PVCs in a row here, we call these paired PVCs or couplets. And that, again, can be more concerning than just having one isolated PVC, as there is a higher risk of that RNT phenomena that we talked about and that we're going to re-talk about here as well. The other thing that starts getting more concerning is when patients are having multiple different morphologies in their PVCs. So their PVCs, they're having multiple shapes. So here we can see this PVC and this PVC and this PVC all look different. And that's more concerning than having one type of PVC because it tells us that their myocardium in their ventricles is more and more irritable because there's multiple spots that are firing when they should not be. The other thing that we start getting concerned about is when we have bigeminies, trigeminies, or quadrigeminies. So those would be PVC every other beat is a bigeminy, a PVC every third beat is a trigeminy, a PVC every fourth beat is a quadrigeminy. Okay, so again, those start being concerning for the fact that they're happening so frequently. And of course, our RNT phenomena. So you can see in this rhythm, the R wave on the PVC hits during the relative refractory period of our T wave. And since the cells have not fully repolarized, because they were in that relative refractory period, it causes the patient to go into this ventricular tachycardia. So if we have if we have three or more PVCs in a row, we would call it a run of VTach. And we're going to talk about this more when we get to ventricular tachycardia. So if you have three or more PVCs, we're going to call it a run of VTach. And if we have up to 30 seconds of PVCs prior to it switching back, we would call it non-sustained ventricular tachycardia. So when to be concerned? So think about generally if we have more than 6 PVCs per minute, we start being concerned. If we have couplets, so multiple PVCs in a row, if we have our bigeminies or trigeminies, we also start getting concerned. Oh, and multiform. We do start getting more concerned if there's multiple foci that these are coming from. Etiologies, there's so many things. As always with all of our rhythms, some patients are going to have PVCs. Normally, again, we generally aren't concerned with them unless they're happening frequently. Things that can cause more PVCs to happen, like is hypoxia, stress, acid-base imbalances, electrolyte imbalances, high sympathetic tone, different medications. So some of these, like, think about all of our patients in hospital. Most of them are having stresses and anxiety. Most of them are going to have, at least for a while, an increased sympathetic tone while their body compensates for their illness. So some of these are not super avoidable. But when we're thinking about patients that have a lot of PVCs, there are some things we can think about correcting, like hypoxia, like acid-base imbalances, like electrolyte imbalances, what medications are they on, things like that. So what do we do for PVCs? Again, if they're infrequent, typically not a concern, patients are usually asymptomatic. They are higher risk if multifocal, or they are frequent, as more frequent PVCs do have the potential to kickstart other ventricular arrhythmias like ventricular fibrillation, like ventricular tachycardia. So we do our best to identify and intervene on the underlying cause. The first true ventricular rhythm that we're going to talk about is called idioventricular rhythms. So if both our sinus node and our AV junction fail, our ventricles will take over as the pacemaker. And that's what an idioventricular rhythm is the sinoatrial node and the AV node pacemakers are not functioning or beating too slow. Something weird is happening, and now the ventricles have taken over as the main pacemaker of the heart. So if we remember from last week, our heart has the 3 intrinsic pacemakers. So our sinoatrial node beats at 60 to 100 beats per minute, our AV node beats at 40 to 60 beats per minute, and our ventricular pacemakers beat at 20 to 40 beats per minute. Okay, so our intrinsic rate at our ventricles is 20 to 40. Therefore, if our ventricles take over as pacemaker, that's generally what their intrinsic rate is. So in our idioventricular rhythms, this just means our ventricles have taken over as the main pacemaker. So therefore, it is a regular rhythm. Our ventricles are going to beat at a normal R-to-R interval. We are not going to have an atrial rhythm, again, because we're not having P waves, because the ventricles initiating that conduction is not able to travel backwards through the AV node. So again, our rate, we're going to have no atrial rate. Our ventricular rate is about 20 to 40 beats per minute. It's going to be about 20 to 40 beats per minute. We can have an accelerated idioventricular rhythm as well. That can be between 40 and 100 beats per minute. And we call that accelerated because it's above the set intrinsic rate of our ventricles. So P waves are absent in this, therefore we cannot measure our PRI interval. And the other distinguishing characteristic of our ventricular rhythms of course, is that they're wide complexes. Okay, so we have a wide and bizarre looking QRS complex that's greater than 0.12 seconds. And generally speaking, our T wave is going to be discordant or the opposite deflection from the main portion of our QRS complex. In these, our QT interval is usually prolonged simply because this is a very slow rhythm, plus we have a wide QRS complex. These patients are at high risk for hemodynamic instability, as you can imagine, just because their rates are really, really, really slow. So why do these happen? Again, the SA node and the AV node fail to generate an impulse, or their intrinsic rates of the AV or SA node are for some reason below the intrinsic rate of our ventricles, allowing them to take over. This can also happen in myocardial infarctions, digoxin toxicity, and electrolyte imbalances. So what do we do? Generally, for idioventricular rhythms, the issue is the patient has low cardiac output due to being bradycardic, right? Their heart rate's too low to sustain a good cardiac output. So the first thing we always want to know is, how is the patient tolerating the rhythm? Do they have any of those primary symptoms of impaired cardiac output, like chest pain, like shortness of breath? Do they have any changes in their LOC, or do they have changes in blood pressure, whether it be hypotension or starting to have a narrowing pulse pressure? So if the patient is stable, whether the patient is stable or unstable, if you have a patient in this rhythm, we need to keep them on the monitor. We need to call the MRP. We need to ensure we have reliable IV access. Okay. If we can figure out the cause, we want to identify and eliminate it. If the patient is stable, MD may ask for temporary pacing pads to be applied but not turned on. The MD might insert a temporary transvenous pacemaker just in case. But generally, I have seen patients in this rhythm that are quite stable, but they always have the potential to be extremely unstable. And this rhythm is never something we're going to leave a patient in for prolonged periods of time. If the patient's stable, we still need to work to figure out what's causing this and work for a long-term solution, because patients cannot be in this rhythm permanently. If the patient's unstable, again, always call your MD, leave these patients on the monitor, administer O2, ensure we have IV access. Think about and identify or eliminate causes if we know them. So again, our causes: is the patient having an MI? Are they on digoxin? Do they have electrolyte imbalances? Are they on beta blockers, calcium channel blockers? Did we just start anything new? Think about whatever you can think about based on the patient that you have. For these, since the issue is the bradycardia, atropine is the thing patients or people think about the most when we're thinking about bradycardia. However, oftentimes with our ventricular rhythms, our atropine is not going to work. And this is simply because atropine works above the ventricles. So if we already know our AV node and our SA node are not functioning, it's unlikely that the IV atropine is going to actually do anything. Often the fix for this is going to be temporary pacing. If the patient is unstable, we usually start transcutaneous because it's fast. And then if we have, if you don't have transcutaneous pacing, or you get one of the patients that only about 80% of patients respond to transcutaneous pacing. So if you have a patient that doesn't respond to transcutaneous pacing, you might try IV dopamine or IV epinephrine, which will also increase our heart rate, or isoproterenol or isopril, which will also increase heart rate. So those are some kind of options. So we basically, with this rhythm, need to do our best to increase the heart rate to stabilize their cardiac output while we figure out what's causing this and what we need to do for a long-term plan. The next rhythm we're going to talk about is ventricular tachycardia. So ventricular tachycardia is an extremely concerning rhythm. It is usually regular, but can be slightly irregular. Again, this is a ventricular rhythm. There's no atrial rate, there's no P wave, there's no PRI interval. if we have a ventricular rhythm that is greater than 100 beats per minute, we would call it a ventricular tachycardia. If the rhythm is between 40 and 100 beats per minute, we call it an accelerated idioventricular. And if it's between 20 and 40, we call it an idioventricular. This being said, ventricular tachycardia greater than 100 beats per minute, generally speaking, they're usually 150 to 250 beats per minute. So they're usually really, really, really fast. Again, our QRS complexes are wide and bizarre looking, and we have discordant T waves. I often find people get confused with where they're looking for their QRS complexes in this. So in this rhythm, you can see here your QRS complex is a downward deflection here, and this is your T wave up here. Okay, so you have your QRS and then your T wave up there. The QT interval in this is unmeasurable. It's just too fast of a rhythm to see where each wave ends and the next begins. If ventricular tachycardia occurs from less than 30 seconds and returns to our underlying rhythm, we would call it, again, a non-sustained ventricular tachycardia. And if we have 3 or more PVCs in a row, we would call it ventricular tachycardia. So we could call it non-sustained, or a run of VTach is what we often say in the clinical setting. The most important thing that I need you to know about ventricular tachycardia is the patients can have a pulse, but they might not. So ventricular tachycardia can be a pulsating rhythm or a non-pulsatile rhythm. So if you ever see this on your monitor, you do not have time to sit and interpret this. So this is a good one to remember what it looks like so that when you see it, you know what it is and you can intervene appropriately. So if you see this on your monitor, first thing you want to do is check your patient. Do they have a pulse? If they do not, we need to start CPR and defibrillate stat. This is another kind of ventricular tachycardia that we can see. So as you can see, going back and forth between, they look quite different. They're both ventricular tachycardia. This one is called torsade de pointe, which is a very characteristic kind of ventricular tachycardia when we have excessive QT interval prolongation. The heart rate in this is very, 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 very rapid, and these patients are very hemodynamically unstable if they haven't already arrested. And if we don't get them out of this quickly, they're going to arrest. The QRS complexes in this is called torsade de pointe because the complexes twist and spiral. And they're going to have these periods of lower amplitude and then periods of higher amplitude. And again, the risk factors for this are prolonged QT interval and electrolyte imbalance, particularly low magnesium. So if you have a patient in torsade that codes, generally speaking, you're going to be ordered to push magnesium on these patients because that is a common cause of torsades. So why does VT happen? So many different things. Again, one of the ones that we keep talking about is our RNT phenomena. So we have a PVC hit or an ectopic beat hit during your RNT or during your relative refractory period, during your T wave, and it flips the patient into VTach. Can also happen for many sort of heart pathologies, acid-base imbalances, trauma, electrolyte imbalances, and different kinds of medication. Interventions for ventricular tachycardia follow 2 distinct pathways. So we have ventricular tachycardia with a pulse and pulseless ventricular tachycardia. So they follow very different algorithms. So if we have a pulse less, so you see ventricular tachycardia and now the patient has no pulse, we would follow the ACLS algorithm for VFib or pulseless VTach. This is a code blue situation. This patient needs to be, CPR needs to be started. We also need to prioritize defibrillation on this patient. This is one of our 2 rhythms that can be defibrillated. And we would give epinephrine and amiodarone. When we have ventricular tachycardia with a pulse, we would follow our ACLS algorithm for wide complex tachycardia, which is further delineated into stable or unstable. So if the patient is in a ventricular tachycardia with a pulse and they are stable, so they don't have any of those signs of impaired cardiac output, we would, generally speaking, convert them back to a regular rhythm, or try to convert them back to a regular rhythm pharmacologically. So IV amio, procainamide. If the patient is unstable or has signs of impaired cardiac output, generally we would move to a synchronized cardioversion. The key here is that it is synchronized. We do not defibrillate patients that are alive. We have to make sure we are in sync mode to make sure we're syncing with the R waves. Okay. And the other thing to remember when we're doing synchronized cardioversion is these patients need pain management and usually conscious sedation because we're applying electricity to their bodies. It can really, really hurt. So generally speaking, always remember that if you have a patient with a pulse, we do not defibrillate them. We would move to a synchronized cardioversion where we're syncing the electricity given with the R wave, and these patients need pain management and sedation. So again, to further go into more detail on our VT with the pulse, we want to know how they're tolerating the rhythm. Other symptoms you might see: headache, dizziness, nausea, vomiting, weakness, syncope. Generally speaking, very generally speaking, always look at your patients, but patients are more likely to be stable if they have a heart rate below 150, and they have a stable blood pressure, of course. So if you see this and your patient does have a pulse and still also has a stable blood pressure, you're still going to call your MD. If you have a rapid response team at your organization, you're still going to call your rapid response team. We still want to administer O2 to these patients. We still want to ensure we have a reliable IV access. It's going to depend on the physician and the patient's presentation on what the physician's going to do. Generally, if the patient's seeming very stable, we might move to treat them pharmacologically rather than electrically with amio or procainamide. If the patient has signs that they're unstable, so they have a pulse, but they do have those symptoms of impaired cardiac output, we're going to call our MRP and or rapid response team, whatever is applicable at your organization, administer oxygen, ensure we have reliable IV access, and generally this would be treated with a synchronized cardioversion. Our next rhythm is ventricular fibrillation. So ventricular fibrillation is a squiggly line, for a lack of a better term. It's fibrillatory waves is how we refer to them, but it's generally chaotic. We cannot assess rate. There's no P waves, there's no PR interval, there's no QRS complexes, we have no T waves. This is always a code blue. So CPR and defib our ventricles in this do not contract, they actually just quiver. So if we remember in atrial fibrillation, our atria kind of go like this. So in VFib, our ventricles do this. So we're losing all of our cardiac output because the ventricles are no longer contracting. They're just kind of sitting there quivering. Okay. So there's two kinds of VFib. So this was what we would call coarse VFib, where we have higher and lower amplitude waves. Whereas this one is fine VFib. So you can see these are way lower amplitude, almost can sometimes look like asystole, but we can see a little bit of the quivering electricity there. So that would be called fine VFib. So this is always a code blue. We need to start CPR and get defibrillation as fast as possible. So what causes ventricular fibrillation? Increase in sympathetic activity. So again, that's our fight or flight response. So the patient's body is secreting our catecholamines, so our epinephrine, our norepinephrine, our cortisol. Our body's in that stress fight or flight mode that can cause the patient to go into VF. Vagal stimulation, electrolyte imbalances, medications. This seems very counterintuitive, but some antiarrhythmics can cause ventricular fibrillation. Some environmental things like electrocution can cause VF. Of course, our heart pathologies and H's and T's. So our H's and T's are our reversible causes of cardiac arrest, which we're going to talk about later in the presentation. So what do? We have a patient in VF or we have a patient in pulseless ventricular tachycardia. This is a code blue. So we need to look, listen, feel, get help, press your code button, call code blue, activate whatever things you know at your organization you have to activate and get this code started, okay? We always will start CPR first. We want to make sure it's hard, it's fast, we get good chest recoil. So we need a rate of 100 to 120 beats per minute with a depth of 5 to 6 centimeters. We usually do 30 compressions to 2 breaths if the patient is not intubated. If the patient is intubated, we switch to continuous CPR with a breath every 6 seconds. The only definitive therapy for VF or pulseless VT is going to be defibrillation. So defibrillation is priority, but it does not beat CPR either. So you want to start CPR, call someone to get the defib, keep doing CPR while they put the pads on. And as soon as the pads are on, you can stop CPR, defibrillate ASAP. As soon as you defibrillate, get back on that chest, CPR for another 2 minutes. So one of the biggest mistakes that we see in practice is after shocking, we do a rhythm check, which is not what we should be doing after defibrillation. Hop back on that chest, 2 more minutes. Then we can do another pulse and rhythm check at the end of the 2 minutes. The other difference when we're doing VF or pulseless VT from our regular codes, for lack of a better term, is we give IV amio or IV lidocaine to help with the arrhythmia. So in addition to giving IV epinephrine 1 milligram Q3 to 5 minutes, we're also going to be giving IV amio. Usually the first dose is 300 milligrams IV push, and the second dose is 150 milligrams IV push, or we can also give lidocaine. The other thing that you might see, especially if a patient has torsades, is IV magnesium sulfate, 1 to 2 grams. The other thing that I learned recently, that depends how old you are to find this helpful, but often we do CPR to staying alive. But I recently saw on social media that we can use Pink Pony Club. So anyone that knows Pink Pony Club, the beat to the chorus is actually 100 to 120 beats per minute. I did check it. So depending what song you like, it can help you stay on tempo. So again, we have VF, pulseless VT. This is a code. Our priority is defibrillation. In addition to our normal code stuff, we also give an antiarrhythmic like amiodarone or lidocaine. Now we're going to move on from ventricular rhythms and talk about our other non-pulsatile rhythms. And so I named it this because in our ventricular rhythms, we have 2 non-pulsatile. We have our VF and our pulseless VT. But we have 2 more types of rhythms that do not have a pulse that are not ventricular rhythms. So our first one is asystole. And this is really the absence of a rhythm, also called a flat line. So there's nothing here to measure. This is just an absence of electrical activity. This is a code blue. This is a CPR stat situation. Our next one that is non-pulsatile is called pulseless electrical activity, or often referred to as PEA. This is electrical activity without mechanical activity. So through the whole series, I've been trying to tell you we can have electrical activity without mechanical activity, so we still always want to physically check a patient's pulse. This is why. We can have this perfectly looking, beautifully organized rhythm on the monitor, yet the patient is not responsive, has no pulse, not breathing. Okay, so for this, if your patient, you see this beautiful rhythm on the monitor, you look at your patient, they're not responding, you check a pulse, they're not breathing. We do not stop to interpret this rhythm. We're going to move on and start a code blue. The electrical activity on the monitor is irrelevant if your patient is dead, okay? So when we're thinking about our PEA, these rhythms can be organized or partially organized, but they're all not going to have a pulse with PEA. And this can happen in a patient's sinus rhythm, AFib, idioventricular rhythms, you name it, all sorts of things. Patients can not have a pulse, and this would be a code blue. Often, this can be due to our H's and our asystole and our PEAs. The thing that I want us to focus on the most when we're thinking about our arrests are H's and T's, which are known as our reversible causes of cardiac arrest. So H's, we have our hypoxia, hypovolemia, hypo or hyperkalemia, hypothermia. We have our hydrogen ions or acidosis. T, we can have toxins, we have cardiac tamponade, a tension pneumo, or we can have a pulmonary or a coronary thrombus. These are all things that we might be able to help fix during the code situation to help get the patient back. And what do we do if a patient's in asystole or PEA? This is our usual BLS code blue situation. So this is our cardiac arrest algorithm. Again, we look, listen, feel, code blue, get help whatever way you can. CPR, we still put defib pads on in case the rhythm changes, but asystole and PEA are not shockable rhythms. We only have two defibrillatable rhythms, which are VT and pulseless V-tach. These are not shockable rhythms. However, please still put the pads on in case the rhythm changes, and do not interrupt CPR to place the pads. As always, ensure we have IV-IO access. We would still give our epi Q3 to 5 minutes. We want to brainstorm and treat our reversible causes. Depending who's there, they may be looking at intubating. If there's no one to intubate, think about an oral pharyngeal airway and a bag valve mask. And 30 compressions to 2 breaths if the patient's not intubated. If you do get an intubation or an advanced airway, we generally then switch to continuous CPR and a breath every 6 seconds. Okay. Next, we're going to move into talking about our reversible causes of cardiac arrest a little bit more. So here's our H's. So the signs are things that you might have seen prior to the patient arresting that can give you hints on what might have caused the arrest. So the first one is hypovolemia. So some signs pre-arrest would be, was the patient tachycardic with a narrow QRS complex? Do they have any obvious blood or fluid loss? And our treatment during a code situation, if you suspect hypovolemia, would of course be IV or IO access, and we'd administer blood or fluid. Generally speaking, if we lose blood, we want to replace blood with blood, but we do our best. For hypoxia, hypoxemia, prior to arresting, you might see a slow heart rate. Sometimes our hypoxic or hypoxemic patients become bradycardic, and they might have showed signs of cyanosis, obviously low SpO2. So we want to, during the code, ensure patent airway, ventilate, and administer oxygen. If the patient had acidosis, some signs that you might see before arrest, other than on an ABG result, is a low amplitude QRS. So of course, if we can, we want to get an ABG. This can help be reversed with ventilation. We might give sodium bicarbonate and dialysis if that's something your facility has access to, / the patient is already set up for that. Hypo or hyperkalemia is another one. So pre-arrest for hypokalemia, you might see a flat T wave or a U wave. So again, after your T wave, if you see a prominent U wave, that can be a sign of hypokalemia. To fix hypokalemia, we would give potassium. If the patient has hyperkalemia prior to arrest, you might see T waves and a wide QRS complex. The fix for hyperkalemia is to shift, so usually using D50 and insulin. Another one is hypothermia. So if your patient's hypothermic, we do our best to heat them up, get bear huggers, give warmed fluids. And one that's not technically an H, but I always add it in as just like because it's quick, something we can think of quick, is hypoglycemia. So check blood sugars. If the patient's super hypoglycemic, can cause a lot of issues. And if you do find, of course, that their blood glucose is less than 4, we can give D50 on physician's orders, of course. Our T's, again, these are other reversible causes of cardiac arrest. Think about a cardiac tamponade. So prior to arrest, you might see a rapid heart rate. You might have, with a narrow QRS complex, you might see jugular vein distension. And if you recently listen to their heart sounds will be muffled as their pericardial sac fills with fluid. The treatment for this is really a pericardiocentesis or thoracotomy. That fluid really needs to be removed from the pericardial sac to allow the heart to fully expand and contract. Often with toxins, we're meaning like overdoses, ingested substances, things like that. So often what you're going to see is the patient had a prolonged QT interval, and the treatment's really going to be based on what the agent ingested or given was. So often, if we're thinking of toxins, we're working with poison control for reversal agents. Tension pneumothorax. So a tension pneumothorax is when we have a pneumothorax with so much pressure that it puts our kind of whole mediastinum under pressure and it starts shifting our mediastinum over to the opposite side. So often prior to arrest, you're going to start seeing a slowing heart rate. We're going to see a narrow QRS complex. Breathing is going to be unequal. So you're going to see maybe good rise in chest fall on one side, but not much at all on the other. The thing that textbooks always tell you to watch for is tracheal deviation, but this is a hugely late sign of tension pneumothorax. So please, please, please do not wait to see a tracheal deviation. The only treatment, again, for this is we need to decompress that side of the chest. So if you can imagine, if we have so much pressure in our one lung that it's pushing everything over, puts too much pressure on our heart to function properly. So we really need to remove that pressure. So we need this to be treated with a needle decompression or a chest tube insertion. The next thing we want to think about is our thrombus. So we could have a pulmonary thrombus, we could have a coronary thrombus. So pulmonary thrombus, you might see a rapid heart rate. Patient will be suddenly short of breath. They might have a sudden decrease in SpO2. They might have chest pain. And treatment for this is going to depend on where you are or what facility you work at. Generally speaking, we just need to try and get rid of that thrombus. So fibrinolytic therapy can be a good option, especially if you're in the periphery in an ED. We might use also, so T and K. We might also use anticoagulants like unfractionated heparin. If we're in the city, they might do an embolectomy, but fibrinolytics is generally the fastest, especially during a code. And for our coronary thrombus, you might see prior to arrest that abnormal ECG, chest pain, dyspnea, our usual sort of STEMI or heart attack symptoms. And to fix this definitively is angioplasty, stent placement, a CABG, so a coronary artery bypass graft. Again, if you're in the periphery, you might see fibrolytic therapy used like T and K to try and dissolve that clot while you can transfer them to another center. So these are, I know it's a lot. These are some of the things to be thinking about while doing all the other things you have to do during a code. So there is a lot, but these are some of the things that we can correct usually in a short period of time if this happens to be one of these things that is causing the arrest. Okay, so that's all the content for today. I'll go into the practice case studies. So as usual, I'm going to go through them a little bit. I'll read them to you. I'll go to the next slide. If you want to take time to interpret it, pause the recording. We'll talk about the interpretation and we'll talk about potential interventions. Okay, so our first case study, we have a 71-year-old patient with a history of angina. Her cardiac monitor is alarming. On entering the room, patient says she has chest pain at 5 on 10. It's radiating to her neck, and the patient is short of breath. She has no nausea, and she's alert and oriented times 4. Her blood pressure is 128 on 90, heart rate of 150, rest rate is 18. But this is what you see on the monitor. So here's what you see on the monitor. So if you would like to take time to interpret it, please pause the recording because I'm going to move on to the interpretation. So this is one of the rhythms that I want you to be able to recognize on a whim. Generally, if your patient has this rhythm, you don't have time to stop and do this lovely 8-step interpretation. We need to be able to realize that this is ventricular tachycardia, and this is a problematic arrhythmia that we need to deal with ASAP. So, again, just a recap, in ventricular tachycardia, we have no atrial rate rhythm because we have no P waves. This is originating in our ventricles, okay? We know it's ventricular tachycardia because we have a rate of 150 beats per minute in this one. Our QRS complexes are wide, so they're greater than 0.12 seconds, and we have our discordant T waves. So T waves are in the opposite direction of our QRS complexes. So this is a ventricular tachycardia. And we know the patient has a pulse because she's speaking to us. She's complaining of chest pain. If the patient was sleeping, not awake, you would have to check a pulse, try and rouse them, etc. So my first question in this is the patient stable or unstable? So we have a patient with chest pain. She is complaining of some shortness of breath, but she's alert and oriented. Blood pressure 128 on 90. Heart rate again 150s, 160s, all the way up to 180 at times. So we're thinking stable or unstable. We want to think of our primary symptoms of impaired cardiac output. So are they having chest pain, shortness of breath, changes in LOC, or changes in blood pressure? So in this case, the patient is having some chest pain, so 5 on 10 chest pain, and she is complaining of some dyspnea. It is important to remember when we're thinking of shortness of breath. Shortness of breath is a subjective, not objective assessment, so we really need to be able to ask the patient, are you feeling short of breath? So given that this patient has 2 out of 4 symptoms minimum of impaired cardiac output, I would call this patient unstable, on the verge of unstable. And during one of our webinars, we had some good discussion about whether this patient's stable or unstable. And it's really hard to know when we don't have a patient sitting in front of us, okay? So given that the patient is having chest pain, I am concerned because this means they're not getting enough oxygen to their myocardium. Okay, so if we're not getting enough oxygen to our myocardium, the patient, that tissue is at risk. Okay. Shortness of breath, it's another issue. They're not probably getting enough oxygen to their lungs. The other thing, which is not as accurate when we're using cuff pressures, but you can see maybe a bit of a narrowing pulse pressure with their systolic and diastolic blood pressure coming a bit closer together. So again, it's really going to depend what the patient looks like. Yeah, I feel like that's where I'm going to end it. Really going to depend what the patient looks like. Being that the patient's having chest pain, shortness of breath, and narrowing pulse pressure, I would call this patient unstable, at risk for deterioration. However, when we're anticipating interventions for this patient is really going to be physician dependent. So if you guys remember when we have stable VTAC with a pulse, which is generally characterized by a heart rate below 150, stable blood pressure with a palpable pulse, we often move to pharmacological interventions like amiodarone, like procainamide. In our unstable VTAC with a pulse, we move to synchronized cardioversion. So it's really going to depend with this case study, and I made it purposefully challenging to try and decipher because patients are always kind of in between, and it's up to us as clinicians to really think about it and think about what could be happening, think about risk for deterioration, what signs that you're looking at. So things that we want to do either way is we want to call our MD or rapid response team if that's something you have access to. Call your team or call your colleagues. We want to administer O2. We want to make sure we have IV or IO access, and we want to talk to our physicians and our interdisciplinary team to see what the plan is. If they decide to do synchronized cardioversion, I think I've said this 3 times, so I apologize, but don't forget about sedation. Don't forget about pain management. And if you have an RT, please call them because they are an amazing resource for us to use during these times. So our next case study, we have a patient that becomes unresponsive. You check for a pulse. Yes, he has one. Yes, he's breathing. You call for help. Vitals are a blood pressure of 70 on 60, heart rate of 36, rest rate of 14. The monitor shows the following rhythm. So here's your rhythm. So please interpret the rhythm if you would like to. So please pause if you would like to. I'm going to move on to the interpretation. So in this rhythm, the rhythm itself is regular. The ventricular rate is about 30 beats per minute. Because we have no P waves, we have no atrial rate, we have no PR interval. The QRS complex itself is wide and bizarre, and it's about 0.2 seconds in this strip. The T wave, this is a typo here, it's not biphasic, it's actually bifid. So the difference between a biphasic and biphasic means it goes above and below the isoelectric line, whereas a bifid means it's notched. Okay, so this is actually a bifid. That's my bad, I apologize. And it is an opposite deflection of our QRS complex. So we can see the majority, or the large part of our QRS complex is negative, and then our T wave is positive. So again, we have that opposite deflection or discordant T wave. QT interval in this measures about 0.6 seconds, which is extremely long. However, when we correct for our QTC, we get 0.42, which is okay. So this rhythm is a idioventricular rhythm, and we know that because it has a rate of 30, we have no P waves, and we have a wide QRS complex. So we know our patient's in an idioventricular rhythm. Is this patient stable or unstable? So this patient is unstable. We have an unstable blood pressure, an extremely low heart rate. We cannot assess for chest pain or shortness of breath because the patient is unconscious. So we know this patient is unstable. So when we have an idioventricular rhythm, what are our possible interventions, or what interventions do you anticipate, and what should we do as nurses? So as nurses, we want to call our MD stat or a rapid response team. Again, we want to ensure we have IV access. We can administer oxygen. Possible medication would be IV atropine, but as I said before, we want to use this cautiously. Atropine is unlikely to improve if there's a block at the bundle of His, preventing anything from getting through. And isolated reports have suggested worsened hemodynamic compromise with the administration of atropine. in these rhythms. So generally speaking, we don't give it, but it is possible to try it, but just know you might get yourself into more of a pickle. So again, as nurses, call your IV or call your MD. We want to think about IV and IO access, give oxygen. You might also be anticipating transcutaneous pacing. If your facility has access to that, again, only about 80% of patients respond to transcutaneous pacing. So if you work at a facility that just has transcutaneous pacing and it's not working for this particular patient, you might have to move to pharmacological interventions like dopamine, like epinephrine, or if you are lucky and have access to it, isoproterenol. Because the problem with these patients is their heart rate is so low that they don't have enough cardiac output. And so when we're thinking about cardiac output, if you guys remember, cardiac output is made up of heart rate and stroke volume. So cardiac output is how many liters per minute of blood our heart pumps per minute. So it's made up of heart rate and stroke volume is the mils per beat. So an easy way to increase their output when they're bradycardic is to increase that heart rate, which should increase their cardiac output. Okay, so we want to think about anything that we can do to get their heart rate back up to improve their cardiac output, which should improve their hemodynamic stability. Our next case study, so we have the patient's SpO2 is alarming low all of a sudden on your cardiac monitor. Upon entering the room, your patient is unresponsive. You check a pulse. The patient is pulseless. You see the following rhythm on the monitor. So patient's alarms beeping off, they have low SpO2. You enter the room, the patient is unresponsive. You cannot rouse them. You check a pulse, they have no pulse. This is the rhythm that you see. So if you want to take time to think about what this could be, pause. I'm going to move on to the next slide. So the biggest takeaway I want you to have here is the rhythm is irrelevant at this point. It's not VF or VTAC. Therefore, and the patient's pulseless. So we need to start CPR. Does not matter what these measurements are. The only way it would matter is if this was VF or VTAC, because that would change our code situation a little bit. But you see something that's not VF or VTAC and your patient doesn't have a pulse, it's irrelevant. Please do not stop and do the measurements on this. The patient's pulseless. This is a code blue. So this is a PEA, or a pulseless electrical activity. So we need to initiate a code blue. So again, CPR, we want to think about airway. So big valve mask with an oropharyngeal airway. Think about intubation. We want to put our defib pads on just in case, because PA is not a shockable rhythm. We want to give epinephrine every 3 to 5 minutes. Do our normal code blue stuff. Our next case study is you get reported for a patient in the ICU awaiting transfer to the ward. The patient was admitted to the ICU with hemodynamic instability due to uncompensated heart failure, but is now well enough to go to the ward. You see the following rhythm on the monitor. The patient does not complain of chest pain, dyspnea, palpitations, dizziness, and his vital signs are stable. So interpret the rhythm and think about what interventions you would anticipate. So here is your rhythm. So again, if you would like to interpret it, please pause. I'm going to move on to the next slide. So the rhythm on this is irregular, but our underlying rhythm is regular. The atrial rate is about 60. Our ventricular rate is 80. And that's because we have these two beats that do not have P waves, which means they're wide and they don't have P wave. Oh, sorry, that's a bad circle. They're wide and they don't have P waves, which means they're ventricular. So those are premature ventricular contractions. Our P waves and our underlying rhythm are upright, rounded, uniform, and again, no P waves in front of our PVCs. When our PRI is present, it's 0.16 approximately, and it's consistent across the strip. Again, please make sure you check it in about 3 spots, and that'll become apparent why next week. QRS is narrow on our regular complexes or underlying rhythm, whereas our PVCs are 0.16 to 0.2, so they are wide. Our T waves are upright, rounded, and the same deflection as our QRS complexes on our regular beats, which is perfect. However, on our PVCs, we have the opposite deflection. So this QRS complex is a downward deflection. We have an upward deflection T wave, and same with the opposite is true with this one. We have an upward deflection QRS and a downward deflection T wave. QT interval is 0.4, and other components. These PVCs are multifocal, and we know that because they look different. Okay, so this is a normal sinus rhythm with multifocal PVCs. Okay, so is this patient stable or unstable? So he's awaiting transfer to the ward. He doesn't complain of chest pain, shortness of breath. His vitals are stable. So he does not have any impaired symptoms of cardiac output. So he would be considered stable. And do you anticipate any interventions for this patient, or do you have any concerns about this patient? And I want you to think about this a little bit because it really depends. So this patient is stable. We now have, if we look back at this rhythm, we have multifocal PVCs. It's hard to see with just this isolated rhythm strip. We'd probably want to do a 12 lead on this patient, depending. But this looks like it could be a quadrigeminy. So is it a PVC every 4th beat? On here it is. Is it constantly on the monitor? I'm not sure. So if we had a PVC every 4th beat and a rate of about 80, that means we would have 20 PVCs a minute, which is a lot. I would probably be concerned about multifocal PVCs and a patient having 20 a minute. That's a lot of PVCs. Puts the patient at significant risk for RNT, going into VFib. We know when we have more PVCs and we have multifocal PVCs that their ventricular myocardium is very irritated. Okay? So intervention-wise, it would really depend what's going on with the patient. The first thing I would want to check, other than checking on my patient, is this new? Has this been happening since admission? Or is this a new finding? I didn't get this in report, which doesn't mean it wasn't happening. Often, especially in critical care, reports are really long. We're all prone to missing things. So it doesn't mean, just because you didn't get a report doesn't mean it's new. We're all human. So I wanted to look back at the previous strips. Is this new? If it's new, I'd want to let the MD know. It could be due to myocardial ischemia, could be due to electrolyte imbalances, could be due to acidosis. If this has been ongoing and the physician team is already aware and the patient's asymptomatic, still monitor closely. And we can also, as nurses, try and think about if there's anything that's bringing this on for the patient. So depending what area you work in, is the patient going through a significantly stressful period of their life? Did they drink, other than being in hospital, did they drink a lot of caffeine? Did their family member bring them an extra large Starbucks coffee? Are they on any sympathomimetic medications? So sympathomimetic medications are medications that mimic our sympathetic nervous system or mimic our fight or flight response. So these can be like salbutamol, dopamine, norepinephrine, things like that. So there's no definitive answer of how to feel about this patient, but the patient is stable, and we want to think about what could be causing this, and really want to know if this is new or not. So I hope that makes sense. Our last case study today is a 68-year-old who was admitted to a monitored unit with community-acquired bacterial pneumonia. The patient was admitted 3 days ago. Today she's been more drowsy, had increased O2 requirements. She was increased from 2 liters to 6 liters. Most recent vital signs were a saturation of 92%, heart rate of 115, blood pressure 135 on 88, temp was 35.8, and a resp rate of 12. She has been in sinus tachycardia since admission with rates between 100 to 120 beats per minute. So the patient's cardiac monitor begins alarming, and this is what you see. So again, if you need a second to think about what this is, pause the video. I'm going to move on to our interpretation. So this again is another one of our rhythms that you really don't have time to pause and do our 8 steps of rhythm interpretation. You need to be able to see this and tell me what it is so quickly, because you need to be able to intervene immediately. So this is ventricular fibrillation. This is a code blue. Our only definitive therapy for this is defibrillation. So the patient is in VFib. So what do you do? So we need to call a code. However you do that in your facility, and start CPR stat. We need to get defib pads in place as quickly as we can without interrupting CPR. So hopefully you have help that comes to the bedside so they can slap the pads on while you're doing CPR, and you guys can coordinate to get the least amount of interruption possible. If you have, use your backboard when possible. The real definitive treatment for this is defib. So when you get the defib on, you do not need to finish your round of CPR. You can stop, defibrillate, and keep going. Depending on your facility, make sure we have at the Ottawa Hospital and ICU, we have a medical directive to apply defibrillation ×1 without a physician present. But you do need a physician's order for this, whether this be a medical directive or the physician there to order it. So don't forget about that piece. The other difference when we're thinking about difference between a PEA or an asystolic arrest versus a VFib or pulseless V-tach arrest is amiodarone. So we give an antiarrhythmic, so amio or lidocaine. I've never seen lidocaine given, but it is an option. So defibrillation and amio are really your differences. You still want to do all the normal code stuff. Give epinephrine Q3 to 5 minutes. Try and or do your big valve mask with an oropharyngeal airway, or if you have a physician or RT present that can intubate. But the difference is really here, defibrillation and the IV antiarrhythmic, whether it be amio or lidocaine. Okay. So that is the end of today's session. I'm so sorry for the delay on this. We had all sorts of complications, so I do apologize for the late sending of this. So hopefully this was helpful. As always, please email me with any questions. Our session starting tomorrow, because I'm so late, is heart blocks. So in this, we're going to talk about atrioventricular blocks. We are going to talk about paced rhythms, and we're going to talk about bundle branch blocks. And I will set an alarm to remind myself to record it so that this does not happen again, and hopefully there are no issues. So again, I apologize for the delay. Thank you so much for listening, and please, please, please email me with any questions. Thanks.